Hi there. Thanks for watching. My name's Adam Lorton. I'm an independent healthcare consultant, and the purpose of this talk is to explore the reimbursement methodology behind CMS Primary Care First, and I'll be doing that through 3 examples of provider practices. If you don't know what CMS Primary Care First is, then let me tell you, you are in the wrong place. Go Google it and then come back and watch this video. This is an intermediate to advanced webinar, talk, whatever the heck this is. This is an intermediate to advanced session to explore some specifics of the reimbursement methodology. So if that's what you came here for, then let's get started. So you probably already know that the reimbursement methodology of Primary Care First has 2 parts. There's a population monthly payment, and then there is an office visit fee. The population monthly payment, you can see it ranges, it's a huge range depending on the aggregate risk of the patient population a provider serves. So the lowest risk patients are worth $24 a month, the highest risk patients as high as $175 a month. So you can see that the middle tier is almost double the implied cost of care of the low tier, and the highest tier, they consider that to be 7 times as costly to treat. And well, who am I to tell them differently? They probably know that. The folks at CMS, pretty good at math. And one thing I have appreciated about this program so far is the level of simplicity. And we can see our fearless leader, Seema Verma, it says that prioritizing simplicity is something that they are valuing higher and higher at Medicare these days, and that's something I applaud them for. Like I mentioned, today we're going to be walking through provider reimbursement using 3 example practices. These practices are run by Casual Carl, Hardworking Helen, and Perfect Petra. These are not real people. The pictures you're seeing are not real providers. They are free to use from unsplash.com. Now, we're going to be meeting Hardworking Helen first. And Hardworking Helen, her patients are average. They're of an average risk profile. They use the hospital an average amount, and they improve their hospital utilization an average amount every year. Let's see how Hardworking Helen gets paid under Primary Care First. Again, every provider in this analysis is going to have 1,000 Medicare beneficiaries for easy math. So if that number doesn't mean anything to you, then double it, cut it in half to a number that does make sense to you. All right, she gets $45 per beneficiary per month because her patients are at aggregate risk level 3. My assumption is that those kind of patients are going to go to the office 3 times a year. So that'd be $12,500 per month. That would be $50 at a time. And so her practice is getting $57,000 a month in total Medicare payments. That is $690,000 per year. Now that's what she gets in year 1. At the end of year 1, there's going to be a pay for performance assessment. And by the way, this would not be a CMS quality program or a CMS program period if it didn't have a competitive pay for performance quality aspect to it. So it's a 4-step process at the end of every year. The first step is a quality gateway. And so the quality gateway requires the provider or the practice to show that their patients are not catastrophically bad at these 5 different categories. So you have to meet the MIPS benchmark. And when it says MIPS benchmark, that just means not being in the worst 20% in the country in these measurements. So Hardworking Helen, her practice passes the quality gateway with flying colors, and she moves on to the next step of the adjustment. And that's called the national adjustment. In the national adjustment, you're going to get penalized. The practice gets penalized if their patients use the hospital at an absurdly high rate, an absurdly unfavorable rate. If they do that, and by the way, Hardworking Helen's patients don't do that. Hardworking Helen's patients are average. If practice's patients use the hospital at an absurdly high rate, then that is a ding, a minus 10% hit that you can never recover from.
Auto shutdown initiated.
This year. You can recover from it in general. All right. So Hardworking Helen, her practice passes the national adjustment and then gets to the cohort adjustment. The cohort adjustment pits your practice against all the practices in the same primary care first risk bucket. So Hardworking Helen, her practice treats patients with aggregate risk level 3. So this would be against all the other level 3 practices. And the question is, how much do your patients use the hospital compared to the rest of the practices in your cohort? If you're worse than average, or sorry, worse than the median, you get nothing. You get 0. I'm assuming Hardworking Helen's patients, they score in the 51st percentile. So just a tick above average, and that nets her a 7% bonus. The last step is the improvement adjustment. And the way the improvement adjustment works is if you're in the bottom half, or sorry, in the worst half in hospital utilization, the most unfavorable half of hospital utilization, your practice automatically gets the tiniest bonus. But if your performance was favorable to the cohort and your improvement in hospital utilization, so that is, are your patients risk adjusted, stratified, all that stuff, are they using the hospital, and by the way, normalized payments, are they using hospital services less than they were the prior year? Well, then you'd be in line for an adjustment. We assume, again, Hardworking Helen's patients are average, and their improvement is average too. She gets the minimum improvement adjustment in the favorable cohort, and that's plus 3.5%. So let's add up these new numbers. She used to make $45 a month. She gets $45 a month per patient. She now gets plus 10.5%, so it's going to be about $50 per beneficiary per month. So let's walk through her new annual revenues. Still 3 visits per patient per year at $50 each. That'd be $12,500, $62,000 a month. And so now, where she used to make $690,000, she makes about $750,000. So a $60,000 raise for having average patients within this program. Now let's meet Casual Carl. Casual Carl, he takes it easy. His patients, they might have some complications and comorbidities. Who's got time to document all that stuff? His patients might use the hospital a lot. Who would even know? And because the performance of these patients is relatively unfavorable, got a lot of potential for improvement. But you're going to see through the walkthrough, that's not going to help Casual Carl in his practice. All right. So Casual Carl's practice cares for 1,000 Medicare beneficiaries at risk level 1, so they get $24 a month. We assume that at risk level 1, these patients aren't coming to the office that often. Once a year is the assumption here. So that makes $28,000 a month in Medicare payments for Casual Carl's practice, $340,000 a year. That is less than half of what... That's a little more than half of what Hardworking Helen's practice pulls in year 1, just from going from risk level 3 now to risk level 1. Okay, let's take Carl through the pay for performance car wash of Primary Care First. Quality Gateway, we're going to assume that Casual Carl's practice passes the Quality Gateway, because even if his patients are unfavorable in some measures, there's a reason he got into this program at all. I mean, if you are failing the Quality Gateway as a Primary Care First practice, what the heck are you doing in this program? You can't be in the top 80% in the country in these 5 measures. I don't think you want to be in this program that has a fairly competitive element to it. All right. So Casual Carl passes the Quality Gateway, moves on to the National Adjustment. Now, we've already discussed that Casual Carl's practices patients, they use the hospital a lot. So he's going to fail the National Adjustment, and that's going to net him minus 10%. A minus 10% that's going to be tough to recover from. Because, well, if he was unfavorable to the nation, you can be pretty darn sure he's going to be unfavorable to his cohort as well. All right? So that's a big fat 0 right there. Improvement adjustment, well, you know that if you're in the unfavorable half of your cohort in terms of total hospital utilization Well, you get the minimum bonus. So he does get a bonus, the minimum bonus in the improvement adjustment. And so that takes away a little bit from his -10, takes him to -6.5. So that would be a new per beneficiary per month payment of $22. So $22,000 a month from Medicare for his 1,000 patients. Same $50 per visit. So that would be now $320,000 from Medicare in year 2 compared to $340,000 in year 1. Okay. Yeah. It's a tough program, Carl. Do you regret signing up for it? You might. I don't know. Now, of course, you're going to be so thrilled to meet Perfect Petra. Perfect Petra, I mean, she's got perfect documentation. Her patients are high-risk patients. She advertises to and attracts high-risk patients, and she documents their risks fastidiously. Compared to other people like her, Perfect Petra's patients, they use the hospital at the perfect rate, which is not all that often, no more often than they need to. And of course, because it's hard to improve on perfection, there's not a lot of room for improvement. Let's see how much Perfect Petra gets paid in primary care first. She's got 1,000 beneficiaries at risk level 5. That's a lot, but it's a lot of money, $175,000 a month. I'm assuming that these patients come to the office relatively often, 5 times a year, $50 a visit. And so that's going to be about $200,000 a month her practice brings in, which is 2.4 million in Medicare payments in year 1. All right. Now, Perfect Petra goes through the PCF car wash. Of course, she passes the quality gateway. A perfect practice couldn't fail the quality gateway. The national adjustment. Do your patients use less than the worst 25% in the country? Well, adjusted for my patient's risk and normalized to my geographic area, of course, my Perfect Petra's patients are perfect. Which brings us to the cohort adjustment. Perfect Petra is competing with other primary care practices that take care of high-risk level 5 patients like she does. But her patients are perfect. So she gets the biggest possible adjustment. Boom. Plus 34%. Improvement, well, like I said, it's tough to improve on perfect, so Perfect Petra's practice is only going to add the minimum 3.5%. But we add all that up, 37.5% total adjustment to a number that seemed pretty high already. Yeah, so that's $241 a month per beneficiary, up from previously $175. Still, $50 a visit for 5 office visits per year. That has her now at $260,000 a month, $3.14 million. Now, I'd like to point out that this is more than triple Hardworking Helen's. This is more than triple Hardworking Helen's. This is more than triple what Hardworking Helen was getting for her level 3 population in year 1. So big difference between level 3 and level 5. Huge difference, a chasm between level 1 and level 5. All right. So quick review. What we learned, or what I hope we took away from this, is that there's a huge variety of possible outcomes with primary care first, and it has very much to do with how much the patients use the hospital. So we saw from Casual Carl, risk level 1 is getting $320,000 to $340,000 a year. Hardworking Helen, risk level 3, $690,000 to $750,000 per year, and then level 5, Perfect Petra, $2.3 to $3.1 million a year. So, like I said, huge differences in what's possible with primary care first. But what CMS likes about this, and what I think some providers will like, is the predictable aspect of knowing what your monthly payment is going to be for an entire year. All right. So, is this how doctors get paid in the future? I have no idea. And CMS has no idea, other than that this is the culmination of 15 years of experimentation. So what do I look for? I look for simplicity, something I could potentially explain to my dad. I also look for aligned incentives, and that's what I really like about this proposal, is that we want doctors to get paid more when they do stuff that's in the best interest of the system. So one thing that's definitely in the best interest of the system is having patients use acute hospital services less, because that costs us all money. Other things that should be incentivized would be proper documentation of complications and comorbidities. Well, if considering that you can get 7 times as much money for a level 5 patient as a level 1 patient, it seems that they are incentivizing that documentation of complications and comorbidities. All right. If you want to learn more about this, feel free to reach out to me, send me an email, send me a LinkedIn request. Happy to talk to you about this because this is stuff that fascinates me. Talk to you later.